So what do guys do when they have erectile dysfunction? As you've heard from my podcast before, there are natural ways that can help. But when natural does not work anymore, what's the process that urologists or sexual medicine professionals use, experts, to get a man functioning again? Today's conversation is with two experts, not one. One of them is Dr. Raphael Carrion, who is the chairman of urology at the University of South Florida. Dr. Carrion was born in Lima, Peru, and his family immigrated in the 1960s. His father was a urologist that came and worked in Miami and specialized in andrology and provided mentorship throughout his education through Raul Jr.'s education. Dr. Carrion has been involved in academic medicine since his training days. He's most proud of mentoring and training the next generation of urologists and has witnessed the graduation of more than 54 residents at the University of South Florida. Dr. Raul Fernandez Crespo is a Tampa-based urologist. He works at the University of South Florida with Dr. Carrion. He trained in medical school and did a residency in Puerto Rico. He then moved to Tampa, where he completed his sexual medicine and fertility fellowship at the University of South Florida under the mentorship of Dr. Raphael Carrion. Our conversation went from the process. You come in and do you start with those PD5 inhibitors, Cialis, Viagra? What do you start with? Then what's next if that doesn't work? And we had an extensive conversation on penile implants. Penile implants, how do they work? For who? When? Which are the different types? This is all, of course, to empower you to know more about male sexuality, how to overcome erectile dysfunction, at least from a medical perspective, and just how to ask better questions. So my conversation with Dr. Carrion and Dr. Fernandez Crespo on all things medical approaches to erectile dysfunction. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Before we begin with our podcast, I'd like to thank our two sponsors for this month. Boston Scientific, leaders in penile implants through their technology, AMS 700. Ask your physician and practitioner on Boston Scientific's penile implants. And XY Vigor, Mr. Happy XY Vigor, leaders in dietary supplements for male health, and XY Vigor for male sexual health. Enjoy the podcast. Welcome to the Dr. Gio podcast. I am your host, Dr. Gio, where it is my intention and my goal to help you optimize your prostate health, testosterone, erections, and how can one live better with age as a man. Today is my great pleasure to have two guests. Probably, I think this is the first time I have two guests. Dr. Raul Fernandez Crespo and Dr. Raphael Carrion, both from University of South Florida. Department of Urology. And Dr. Carrion is the chief of that department. So, his busy day, Dr. Crespo's busy day, here we are having this conversation on erectile dysfunction. Guys, thank you very, very much for joining me today.
Gio, thank you for the invitation for both of us, and let Raul speak. It's an honor to be on tonight.
Yeah, it truly is. And thank you for having us, definitely.
So recently I was at the American Urological Association meeting in San Antonio. Hopefully the last time we ever have a meeting in San Antonio. There wasn't a whole lot going on there. But one of the things that happened was, these events that happened. And I met one of your uro-onc urologists there, Trushar, who was amazing. And I knew him from the Columbia days because that's when I met him when I was working in Columbia with Aaron Katz. And he says, you got to have Dr. Carrion and Dr. Crespo. We have a great team on male reproduction. I was like, really? So he tell me more. It's like, yeah, people come from all over. Dr. Carrion is the chief of the department. He's amazing. I was like, wow. So he made the introduction, and here we are. I'm so grateful for him to letting me know about your program. Why don't you go ahead? Let's start with you, Raphael. Tell me about the program. Tell me, you could start with the whole department and then narrow it down to your male reproduction program, which sounds fascinating.
So University of South Florida is located in Tampa. Unlike certain cities like New York, Chicago, LA, Florida doesn't have too many programs in the same city. So Tampa only has as its only clinical academic center the University of South Florida. So we're a department of urology. And for the most part, like most departments, obviously NYU is a bigger department. We are smaller, we are younger, but we are growing. And so we have, you mentioned a Columbia export, Trushar Patel, who is our minimally invasive cancer specialist, our cancer guy. And he is exceedingly busy and absolutely a superstar. And so that shows you, first, let me give the disclaimer, I'm the oldest one in the department. And it's crazy to think that I wake up one day and I'm the old man. But that's testament to the department that's growing, that has young energy, very aspiring professionals. And I am exceedingly proud of the department and USF because it's making a lot of strides with Tampa General Hospital, really having national headshots in terms of prominence. Now, sexual medicine, the reproductive group, like you just mentioned, we take special pride in sexual medicine. Why? Because we are 3 full-time faculty. You're staring at the other one, Raul Fernandez. The other one is Justin Parker. We have 2 APPs, which are PAs, right? Physician assistants, only sexual medicine. And then we have 2 clinical fellows that come as clinical instructors. What does that mean? Because you know what a fellow is, right? They're following the team. No. Our fellows are learning from us, but they're independent providers as well. So if you really do the math of 3, 2, and 2, that is 7 providers dedicated full-time to sexual medicine at USF. That alone is my bragging rights in terms of a very serious center trying to manage this kind of pathology. But I'll pause there because you'll get me salivating and it'll look nepotistic.
Well, let me tell you, that sounds, I don't know of another program like that. I mean, Erwin Goldstein in San Diego, I mean, but he's in a private clinic, right? And he's one of the gurus, but maybe he's that busy. But I just don't know of another academic center that has such a, what it sounds like, a strong male reproduction center.
Correct. That is correct. It is robust and it is busy. It is busy.
Well, for you to have, I mean, I'm sure everybody's eating just fine. So I'm sure that you guys are seeing quite a few patients. Dr. Raul Fernandez Crespo. You always love the Latin names. There's always like 3 or 4 last names in a row. You cannot, it's the most unbelievable. If I would have been born in Cuba, probably I would have had 3 or 4 because my mother wanted to implement that when I was born. You know, Espineta, Espinosa, Del Toro.
Yeah, you got to have at least 2 of them.
Raul, tell me about you. So you did a fellowship, or you did a fellowship at USF, and then you stayed on. They kept you. You must have done a good job. Tell me about your history with regards to your training.
So yeah, I did my medical school and my residency program, urology residency program, both in Puerto Rico, and then I came over to USF under Dr. Carrion's wing only for the fellowship. And then I ended up being enamored with the program, with the team, and how everything was kind of like working up and growing. And they made me a really good offer that I couldn't resist. So instead of going back to the island, I definitely decided to stay here and be part of the team.
Well, listen, I mean, you're only 30 minutes away from the island, 45 minutes away from the island, a good
More
flight.
or less,
So,
yeah.
I mean, it's not like, and then you got similar weather. It's not like you're in New York, so where the weather, today was fine, but it gets cold. I don't feel sorry for you, man. I mean, I think that,
no, but I have to say, it does get a little colder than what I was expecting.
Oh my, Raul, rules number 1, you never tell a New Yorker ever that it gets cold in Florida ever, because no one is going to
No one
feel
will
sorry for
believe me.
you.
I know. But I do have to say it because I'm probably the only person in Florida that actually wears coats and scarves as needed. Yeah.
Raphael, tell me, so how does it work? So when a patient comes, how do you guys determine who gets the patient? For, let's say they're calling for ED.
Fair.
Who gets that patient? Is it Dr. Parker? Is it Dr. Fernandez Crespo? Is it you? How is that determined?
Excellent question for a big team. It starts with first a specific request. So if Gio has a cousin who moved, as most New Yorkers have, to Florida, and he lives close to Tampa and has ED, and you knew who I was, and you said, hey, go see Carrion at USF. The computer grid for the navigation, just to keep the story short and simple, will honor a specific request. Hey, I am coming because I am only coming to see Carrion. But in our sexual medicine algorithm, it'll also let them know that, hey, but if you want to see Dr. Fernandez and keep a Spanish speaking option, let's say, if you want to see Dr. Parker at a different site or a different date, because I don't have clinics 5 days a week, right? Some people can come, let's say, just on a Monday. And let's say Raul carves out a Monday a month, I believe. I don't have any Monday slots. I'm in surgery. So we like to let them know that, hey, we can honor you to see Carrion. But if you want more flexibility in the date and location, here's the other two MD providers or fellows that are graduates but still learning their trade. They can see you even sooner if there's any delay. And then, of course, our nurse practitioners. But they are very clear in terms of providing the summary statement of. So there are patients that say, hey, I'm not going to wait a couple months to see Carrion. I'm going to see Raul Fernandez on a Monday by Tampa General. That's going to work for me because I know he's part of the team. And so that's kind of the algorithm.
Oh, that's beautiful. So what is the process? So as you guys, we spoke before we started recording. We'd never met before. And I gave you an intro. I said, look, I'm a natural medicine guy. Like I want my patients to do natural things. I want them to improve their sleep. I want them to improve their diet, exercise, and everything is very prescriptive. Perhaps some botanicals that hopefully I get to talk at the next sexual meeting and about to educate you guys on. But I do find that at some point, sometimes they need something else, whether you start with pills and then you move from there. What's the process in your practice where you evaluate, all right, we start with what, and then move on to what is that process? And I know that that's a big question because it depends on many things. Don't go into the post-prostatectomy scenario yet or the post-prostate treatment yet. We'll go there. But let's say a guy that has his prostate intact, 52-year-old guy, serious ED. What's that process?
Let's hear what Raul has to say. The algorithm is interesting, but I'll hear what Dr. Fernandez says.
So yeah, I mean, typically those patients, many of them, for the most part, when they come to us, they've already tried oral medications. It's not unreasonable to just, if they have not, to basically just start them on some oral medication just to see how they respond to it. And if they fail the oral therapy, or if they've come to us already having failed the oral therapy, then we'll talk about all the different options, including like intraurethral gels, injections, vacuum devices, and of course, we're going to be talking as well regarding penile implants. And they don't have to go through all of them just so that if they want a penile implant, just so that we can actually get them one. I mean, it all depends on, some patients are not interested in doing injections, others are not interested in doing gels, or they would rather just have the implant done. I mean, it all depends on what the patient wants, but typically for the most part, we at least want to try at least one treatment modality before we keep moving forward into a more invasive option, such as a surgical option.
What is your, and Raphael, I also want to hear from you. I wonder, I find, look, I don't prescribe almost anything, a pharmaceutical, but I do have an affinity for tadalafil more than the others. And maybe it's just a me thing. How about you guys? There's about at least 3 in the market. Maybe there's more. But do you have an affinity for tadalafil versus sildenafil, or Cialis versus Viagra? Or how do you guys go about prescribing the drugs?
You come and touch a home base only because in New York, there's a prominent andrologist at Memorial Sloan Kettering.
Yeah.
I won't mention his name, but he's a huge advocate of sildenafil citrate Viagra.
Yeah.
He sometimes extrapolates some of the take-home messages from data to say sildenafil is better than tadalafil. Man, when it comes to these pills, the pharmaceutical agents that help you with erections, there really is no superiority. There's only differences in the drug. So tadalafil, Cialis, lasts longer in the system. So if I'm going to carve out a rehabilitative program, sir, I want nitric oxide, the element that these drugs give. It's a specialized oxygen. When I explain to the patient, I want you to be bathing in this oxygen. When we talk in layman terms, I want you to bathe in this oxygen. So tadalafil or Cialis, it's the same thing, literally plays an advantage for me because I could have you take it Monday, Wednesday, Friday, and it covers you for the week. But if I'm going to use Viagra, which is sildenafil with an S, that one you almost have to take every day because it gets out of your system. So if I want to take Geo and I want to nourish the penile tissues with oxygen all the time to heal, now I'm going to use tadalafil because it's better. It's more user-friendly. So you could start to see how...
And is the only PDE5 inhibitor that also shows prostate benefits and helps with that as well. Is that right?
That is correct. Absolutely. Yeah. Now, in real scientific data, sildenafil also, but it's so short-term. Pfizer back then, before it went generic, found that it was way too expensive and too cumbersome to go to the FDA to get, they would have had to do BID or TID dosing daily for the
twice a day or 3 times a day.
Sorry.
That's all right.
Twice a day or 3 times a day, sildenafil, so that they could pee as good as the guy taking a daily Cialis. And it was too cumbersome, too expensive. You
sound very much like you are more aligned with Cialis and tadalafil, just like I am, than the others. I don't know. I don't know.
Try not to be biased.
Raul, is that a similar approach? What's your favorite PDE5 inhibitor?
I definitely echo what Dr. Carrion is mentioning, and just the fact that also if it does have a longer time frame within the body, like such as the tadalafil, also, then the patients not necessarily need to be preparing or making sure that they take a medication an hour before on an empty stomach in order for them to have adequate erections and adequate sexual activity. They can just take it in the morning or in the afternoon, and they still have to plan it, but they don't have to plan it as much as the sildenafil with the Viagra. So it does have certain benefits if you were to compare one or the other. So definitely that planning that most of the patients, they want to keep or have that, or try to have that spontaneity. If we were to compare one or the other, definitely the tadalafil will allow a little bit more spontaneity and less planning actually than if you were to compare it with the Viagra or the sildenafil, especially since it's also not affected by food or whatnot, so they don't have to be starving or fasting in order to take the medication so that they can actually eventually perform sexually.
And fasting is a therapeutic thing that people are doing there these days. They're doing, intermittent fasting and time restricted eating and all these things. So you want to make sure that they could take it on an empty stomach. Whatever happened to Levitra?
But it's pricey. But Levitra's still here. I prescribe a little bit. I don't know about Raul, but not much.
Listen, I haven't heard. I don't even know. I just don't know anyone who prescribes, not even the supralingual, which I've known about. And it sounds great, right? It's right close to your blood vessels, probably works faster.
Gio, it's amazing, especially for the patient that hates swallowing a pill.
Yeah.
I don't have many patients either on vardenafil or even on avanafil,
that's the last one.
The quick, even quicker acting. It's so expensive since there are no generic options that for the most part, I could probably have a handful of them only.
So with the tadalafil and the sildenafil, there's been studies, books written on the fact that generic drugs they oftentimes are not the real deal. So patients don't get, they don't get the same benefits. Have you found that to be a problem in the sexual medicine space?
The bootleg medications before they went generic, they were everywhere. You ask Fernandez and any other urologist or even family practice, how many people went online and got their fake bootleg Viagra from China, Asia, South America, Africa? There were these pill mills that are totally illegal, but they were marketing to the American clientele because everyone's going to buy it. Now, let's switch to the post generic phase because now Viagra and Cialis are available generically and cheap. Now you have nationally a bunch of producers giving the American consumer this product. At first, I thought naively, well, clearly, biochemically, it's going to be the natural powder of sildenafil citrate and it's going to be the pure thing. Turns out false. There are differences in which company. And unfortunately, I don't like to quote too much, so I will pause. I cannot give you names or vendors, or be wary if your neighborhood CVS or Walgreens is selling you the generic Viagra from this company because it's been known to give not so much accurate kinetic active drug, but it's there. And in fact, I've had a couple patients, especially those that are in the science world, tell me, Carrion, when you write this, can you write the specific vendor? Because I went to Walgreens and when I refilled it from a different company, it didn't work as good. So unfortunately, it's real. But the problem, Gio, is it takes a lot of money to analyze this. Because you could easily, and your public that's listening to this saying, well, clearly there's some task force to knock, to crack heads and really separate the phonies.
regulate that process more. No,
Once it goes generic, it is horrible. Once it goes generic, it's horrible because it has political implications, right? You're allowing easy access for the public to get this on a cheaper basis. So very few people are going to crack down on, as long as they don't put, I'm going to say this facetiously, as long as they don't put poison, you're not going to be regulated.
Right. Yes, it's like the dietary supplement industry, not that different. If right now you want to put a formula together, you could. No one will stop you, and only if someone has a bad effect or ill effect, they'll crack down on your supplement business. Same thing, which is a little bit of the wild west in the supplement world, and that's something I'm very familiar with in terms of the whole how dietary supplements work, manufacturing, and that process. Wow, I actually didn't know that. I thought it was more. I didn't know that the brand names were more regulated than the generic. I thought it was just the same process. Interesting.
It's a little looser. And then I thought that they all get their powder from Pfizer, but it turns out you can manufacture your own chemical as well, and that's where you get a bandwidth of some variants.
How often have you guys seen that being a problem? So you prescribe the generic, it's not working. And I remember having the actual brand name and that worked better. How often you think you have that problem?
Raul, don't you have patients that tell you, only give me the brand name because the other one didn't work?
Yeah, for sure. I mean, it's not something that we see a lot, but definitely I have a fair amount of patients that would tell me, hey, I remember I was using the brand name and I was doing great. And then after we switch over to the generic, I feel like it's not working as much. And initially I was like, well, I mean, there may be a psychogenic component to it, but actually there may be a problem with it. And definitely there are some patients that will respond a lot better to the brand one versus the generic one. And that's something to definitely take into consideration when they're not responding to the medication.
So, what are people getting from Roman and Hims and all those online companies? And it's definitely not the brand name because I don't think that's sustainable for their business. So I wonder what they're getting.
They partner with one company, national, that'll fabricate this generically at large scale and roll with it. But they will partner with one company. Now, Hims got so big that they can explore and one of a formidable andrologist actually from Columbia left to be employed, I believe, by him. So they
from Columbia University or the country?
No, Columbia University. I think he resigned 2 years ago, maybe 3. Work actually for Hims.
Okay.
Yeah. If I misspeak, don't hammer me on the comments. but I am almost.
I'm gonna look that person up. I didn't. Did I know
Yeah,
that? I don't know if
I
I
am
knew that.
almost 90% sure. And True Patel knows it.
Yep. Cool.
Yeah.
So, how often we're talking about a 52-year-old man here? By the way, I know you guys have seen younger men with ED. I've seen, God, and of course, the younger guys don't want drugs, so they see me, right? So I'm talking about young, like 30, 25. Like, I have a few college students.
Absolutely.
When you and I, when the three of us, I mean, although Raul looks like he just graduated from college, so, but let's just say you're just a couple of years younger than me and Raphael. I'm just going by your comments on how old you are, but I think you look great too. When we were in college, I mean, there was no, if there was any ED, I don't know. I didn't see it. I mean, the opposite was true. A lot of horny guys going around. I see a lot of young guys with ED. So I'm at risk of digressing, but how often do you see guys in their, younger than coming with ED?
I'd say a fair amount. I mean, we're not seeing, I think that probably like a third of the patients that we see, or at least that I see in clinics, are less than, are some in their 20s, 30s, and 40s. And I think it has to do with the fact that this was a sort of like taboo or something that no one wanted to speak about. And if you had ED, you were just like being quiet about it. And now with things are being more and more accessible, definitely more people have access to these drugs, and they can talk about these other issues that they're having. And definitely that comparing, and we are not that far off, but definitely 20 years ago versus 30 years ago versus 10 years ago, definitely these patients or these people that are suffering from erectile dysfunction are able to talk more about this, and definitely the stigma is much less. There's still some stigma that we definitely need to tackle that, but there is a lot less stigma about males talking about their sexual health now than it was probably 20 years ago.
Let me ask a provocative question. There's a sexual medicine doctor in Miami. Her name is Lisa Paz, P-A-Z. She's fabulous. I had her on the podcast.
I heard her. She's awesome.
So I posed a question. I said, look, what do you think is the percentage with young men with ED that, you don't want to oversimplify, right? But excessive pornography watching is a problem. And it seems to be that it's not insignificant. Now, she has a different twist. I also had Justin Dubin on. He's great because he brings the goods and a lot of personality, which is amazing. And I asked him the same question. They both said, yeah, it's a problem. Yeah, sure, it's a problem. But there's a way of using it positively. I said, well, I never heard that. How can you use porn positively, right? And I guess the takeaway, and that's not to go too far out on this, is that, well, females can actually learn how to be more sexual. If you get the female involved, assuming that it's a heterosexual relationship, females can actually benefit. Males probably causing, erectile issues. So anyway, we'll move on. I'll let the listener look for Lisa Paz and Dr. Justin Dubin. Excellent. I forgot the episodes, but we'll put it on our show notes. All right. So let's just say the 52-year-old guy, why don't the pills work? Like, what's happening that they're not old, and as you get older, as I get older, 52 is definitely not old. Why aren't the pills working, and what's next? Raphael. Hey, friends. This month is our 4-part series on the Dr. Gio podcast on male sexual health. And with that in mind, I'd like to thank our sponsor, Boston Scientific. I'm so excited to collaborate with Boston Scientific, a leader dedicated to transforming lives through innovative and medical solutions that improve patients' lives and health globally. Erectile dysfunction, ED, is a common condition affecting 1 in 5 American men as young as 20 years old and older. If you have ED, know that it is treatable with various options such as medical solutions, natural solutions, lifestyle changes, medications, vacuum devices, injections, and penile implants. Boston Scientific's AMS 700 inflatable penile prosthesis is a long-term treatment designed to closely mimic a natural erection, providing rigidity when inflated and a natural flaccid appearance when it's deflated. To learn more about ED treatment options, visit the link below, ED Cure, or ask your healthcare practitioner for the best treatment options for you.
Sticking on biological factors, let's
Right.
park psychogenic factors aside.
Mm-hmm.
But sticking biological, of course, just like Raul was saying, we see them younger, and this is a low 50-year-old. So why would he have severe ED? Severe ED would, to me, means the pills are not managing it and helping him get by. Well, sir, when's the last time you were compliant with your diabetes? When's the last time
Right.
you follow up with your
Metabolic
primary care?
syndrome and all those things. Yeah.
Sir, your hypertension, oh my goodness, your blood pressure is off the roof.
Right.
Or
Right.
you're overdosing and you're too aggressively managed with your high blood pressure, and it's hypotensive because the blood pressure medications can cause ED also.
Mm-hmm.
You're like
Mm-hmm.
a no-win situation when you're a
Yeah.
high blood
Yeah.
pressure. And what, right there, Gio, I could stop there by saying, what is the frequency and the incidence of diabetes and high blood pressure in this country? Well, right there, that'll keep anyone's office busy.
Right.
Just off those two.
So the PDE5 inhibitors, because one would think, listen, I know the issues. I'm not taking good care. I'm not exercising, but I have to get busy. I have this date tonight. It's Friday night, second date. Can the pills override whatever other health condition I have? And what you're probably saying is maybe sometimes, but no, many times it doesn't override that. Is that right?
That is correct. And then keep in mind that an astute urologist dedicated at this would know how to be aggressive with the pill. Here's one big fallacy. I'm that 50-year-old, severe diabetes, but carry on. It was Mother's Day not that long ago. I need this weekend to work, even though mom might not be thinking about it, but the dad is. And so he's getting things ready and it's got to work. Well, if you haven't taken that Viagra or Cialis for 3 months because you're not very sexually active, it's not working, I'm a little depressed, or we're busy, and if you take it only that weekend for Mother's Day, it's not going to work. So that's another strategy. Optimize the formula and the way you're going to take these pills to make sure it's success. And that is frequency. You got to be taking these pills in a frequent format that works with guidance from your doctor.
Raul, what are the side effects with that, right? So, for example, Tadalafil, our favorite, they should be sponsoring this podcast. You know, the way we're talking about Tadalafil, right? I have patients take 5 milligrams a day every day with some supplements. I'll send you guys a study. They looked at Tadalafil that worked better with an antioxidant than by itself. That combination worked better, and it does. Anyway, Tadalafil, 5 milligrams a day, no side effects ever. I mean, it's almost like a supplement, in my opinion. Promotes nitric oxide. You get higher, more side effects, more, flushing of the face. There was an association with lower back pain with Tadalafil that used to be the case, and not so much with all the other ones. Maybe you could speak on that. So my question is, what's the dosage that you get them on? What's the right dosage? And I know it depends on many things that, well, they get the benefits, but not the adverse events.
So, I mean, I think it's like typically with anything, starting them off on the lowest dosage and see how they tolerate the medication, the side effects, and the efficacy of the medication. So, I mean, I had a couple of patients that they do develop just some like reflux just on the 5 milligrams, and then we would then tell them to just take 2.5 instead of the 5. So we have others that do develop the back pain or the calf pain that you're mentioning, and comparing the Tadalafil or the Cialis versus the sildenafil, definitely it will target a specific type of receptor that the sildenafil does not, which can cause the muscle ache. So, I mean, all of those things we have to take into consideration. But typically, we start them off at the lowest dose and then slowly work it up and see if they're able to tolerate it, to see if they're having actually results with it, and just benefit and just managing the side effects. Because for some patients, they do develop some flushing or headaches with the Viagra, others don't with the Tadalafil. So it all depends on. So it's kind of like a trial and see which one would suit them best in terms of side effects. But typically, we would start it off at least I do on the lowest dose, and then work our way up as needed. Because you can get good results with 5 or 10 milligrams of the dialofil. Why go ahead and give them the 20 milligrams, which we know for a fact it's going to be much more medication, and it can actually increase the risk for side effects. So it's kind of like balancing it out. So at least I typically just started off fairly slow or low dosing, and then work our way up, and just making sure that they do get the best results with the least amount of side effects.
Good. What's next? So it's not working. Are the injections next? If so, what's your approach with that? I can't tell you the amount of guys. Once again, I don't prescribe any of these things, but they're my patient, they're somebody else's patient, and they're either emailing me, yeah, I'm in the ER with priapism. So, which is an erection that doesn't go down within, I don't know, 2 to 3 hours or so. And that's a visit to the ER. So are the injections next, and how does it work?
So those patients, we tell them, be careful what you wish for, right? Because we don't want them to have too much of an erection. So it's the same principle that we typically
a problem that most guys wish they had until they have it.
Yeah,
and then they're like, wow, this is the worst. This is actually painful. And then they're like, yeah, I don't want this ever again. Yeah, right.
So it's exactly the same. So we go ahead and do the same approach that we actually do with the oral medications. I will tell them off the bat, even from the get-go, hey, the first thing, if we have to start you on the lowest dose, and it may be, just don't get disheartened, because it may take a couple of trials before we actually find the actual dosage that's right for you. But we cannot overdo it, because then we can get that prolonged erection, which can then cause a bunch of other problems, not even necessarily the pain, but all the sequela that it can actually cause. So the same thing is, we start them on low, we bring them to the office, we take a look we do a sonogram or a penile Doppler, see what the main problem is, we teach them how to do the injections, we see the response that they have when we do the ultrasound at the clinic, and then from there we go and we teach them how to slowly start titrating the dosage of the medication, so that they can get the best results, a good erection, a firm, rigid erection that's enough for sexual penetration, that after they complete the sexual activity, then it goes down. Because what we don't want is for them, like you were saying, to have that prolonged erection after finishing sexual activity, which does not go down. And then now what do we do? So all those, and then the other thing is just telling them up front, hey, if this were to happen, this is what you have to do, so it does not get them by surprise. But I mean, I think by slowly titrating their dosage and being upfront and telling them, hey, it may take 2-3 times, or it may take 10 times for you to get to the proper dosage. We cannot overdo it and just skip the steps, because that's when we can get into trouble.
Right. So I cannot imagine trimix or the injections. I know it's not only trimix, but the injections not working. But some guys are just not going to inject their penis. Period. End of story. That's just not going to happen. And in some guys, for some reason, it doesn't work. Maybe after prostate treatment and things like that. You guys seem to be experts in the penile implant. So I spend a good amount of my time in some patients post-prostatectomy who are really motivated to getting there. And a few guys, even without prostatectomy, without even prostate cancer history, sort of informing them. Again, I for many of my patients, I'm the trusted source, because they have trust issues with MDs. Right? They're like, if you have a hammer, they feel like if you have a hammer, everything looks like a nail. They feel like you're just always trying to sell them something. So they come to me and I'm the one always defending the MDs. I'm like, no. I know the issues, and there are issues, but when these things work, they work. Penile implant to me is one of those things. It's a surgical procedure. Back in the day when I started working in urology over 20 years ago with Dr. Valenzuela, the penile implant man, and I'm not talking about the surgeon, I'm talking about the user, was Andres Garcia, which, Raul, I have to say, you look a lot like Andres Garcia. I'm just saying. I mean, for the listener, you got to look up this guy. I mean, first of all, it's a compliment, man. This guy was even I would say it as a happy heterosexual man. This guy was handsome. Yeah. This guy was the man. So I think he went through like about 3 implants from overuse, right? 3. And he put it on the mat, la pompita, right? In Spanish, they called it. Yeah. And then things in the Spanish, market for sure, it blew up. So I have a few questions. Number one is I'm interested in what's the demographic? Is it still because I think the Spanish guys are horny guys, right? So do your population, is it still mostly Spanish or Latinos or from Spanish speaking countries? And then what's your approach to saying, yep, you need an implant? So those are two questions. Go ahead, Raphael.
Well, I can't help but at least give a disclaimer. Andre Garcia, his third implant was done in Miami by Dr. Carrion, not this one, Carrion Senior. And I was flown in from Tampa because I was brand new.
Is that your dad?
That's my father.
So your dad was a urologist. I didn't know that.
Yes. And don't get me started. One of the implants in our history is named small carrion penile prosthesis, but it was a malleable, not an inflatable. But that's an aside.
Fascinating. No, it's fascinating. Actually, I love history. So yeah.
So he placed the third one in Andres Garcia, and that's the one he took to the grave because he passed away last year. So
right.
That is Andre Garcia, and that's how La Bombita gets born. So that's an aside. So in the world, we call it patient cohorts. Cohorts means groups, special groups of something. So patient cohorts means, like you just said, Hispanic patients, Latino patients. They tend to be a little more pro-sexual health seeking. Hey, when my manhood is in jeopardy, I don't feel like a man. So I need to be back to being a man. And so it's no surprise that Florida, South Florida, and the rest of the state, it is very aggressive, and it's one of the top 2 states in terms of volume of penile implantation. Not necessarily do we happen to have the most severe ED in the rest. No, that can't be a true statement. What it does have, though, is a very aggressive patient population, part of it Latino, that is seeking help very aggressively, saying, I need to be back in the game now. And if I don't get back in the game,
yeah, there's an urgency, right? There seems to be an urgency there.
Yeah, if I don't get back to the game soon, this is a problem. I don't feel the same. My mission and my default setting has been compromised. So yeah, so clearly we see a mixture of demographics, right? Different patient, but the Latino patient population is definitely aggressive in terms of seeking help for their sexual health.
And so, Raul, what's that process? So when do you say, yep, this is the only way, you've gone through through other things, and this is the only other solution for you?
So, I mean, I typically, and I think Dr. Carrion is probably similar. Within that first visit that the patient comes in, we're just going to lay out all the treatment options, because at the end of the day, they don't have the notion that like a couple of years ago was that they have to go through all the treatments in order for them to be a candidate for a penile implant. That's not necessarily the case anymore. Like, honestly, we'll just lay out all the treatment options within that first visit, and each time that they feel like either whatever they're doing or their treatment options are not working, we'll just go ahead and revisit all the treatment options again, and we'll let them choose. Like, we'll give them all the pros and cons of each option, and we're here for them. So it's whatever they want, as long as it's within reason, of course. But yeah, I mean, it doesn't necessarily mean that, if you failed the oral medications, then we have to do the implants or the injections, then the vacuum or the urethral gels, I mean, that's not really the case. At the end of the day, as long as we're laying all the options to them throughout all their treatment plans, then they know because they can actually make an informed decision as to what they want, instead of us being the ones telling them, now you have to do this, or now you have to do this other thing. So that way they can make up their own decision, with us, of course, guiding them as to what should be the proper way or the next reasonable step. Because if a 26-year-old with no like real or significant pathology comes in that has failed a couple of times a Viagra and wants an implant, that's not that reasonable. Let's call it. But I mean, we've implanted patients in their 20s because they do have other pathologies. But yeah, I mean, it's not that we're not going to be doing it, but I mean, we want the patient to be the one kind of guiding what decision they want with our guidance.
So what's the infertility like? Is it 100% in younger men with an implant?
Well, no, I mean, the implant is not going to be affecting fertility at all. Like, if or it's
Interesting.
the same. So whenever we tell patients with implants, the implant is not going to help you with orgasm, sensation, ejaculation, anything at all. The implant is only going to help you get hard. The implant will help only with the rigidity. If you were not having fertility problems before, once we get the implant, then you will not have fertility problems. If you were having fertility problems before, then the same will be after the implant, because we're not going to touch anything other than making sure that the patient gets hard. That's going to be our main goal with the implant only. Like whatever was there before will still be there after, except that now you're going to have a hard penis.
And what is the LGBT population that comes to see you for penile implants? Raphael, I see you nodding your head up and down.
Actually, Gio, I will defer because we've had Raul Fernandez specifically cater and target and educate back to that term cohort, this cohort domain.
So, I mean, I think we definitely are starting to see more and more patients within the LGBTQ plus community seeking not only issues with asking for implants, but just like overall erectile function. And there are a couple of articles, and we actually wrote one not that long ago, a couple of years ago, along with one of our colleagues over in Mount Sinai, Dr. Cordone, that actually about all the sexual dysfunctions among this cohort of patients. And definitely, it's I think with time we're seeing more and more patients within that specific group, and it's great that we're being more visible to that patient population, and that fact that patient population is actually feeling more and more comfortable with their providers talking about openly about their sexual problems. That way we're able to help them just as we would all the patients that come to our office.
Oh, fascinating. That's great. Who's not a candidate for penile implant? So what are you looking for? Is you can't, this is not for you. Who's that, Raphael?
Well, Raul gave one already away, and that early patient that may have more psychogenic etiology, very little organic, misread. We've had patients come to our clinic requesting a penile implant. They thought it was going to make their penis larger. They thought little mythical truths about what a penile implant's all about. Those are discarded immediately because you got to have real reason. So cutting to the chase, Gio, it is invasive. It is surgery. It has its own dialogue and discussion on risks by having surgery. On the upside, tremendous.
No pun intended.
We talked about natural. Whenever you see Gio, you think nature, you think natural, you think holistic, right? No erection is as good as the natural great erection you had early in life. There's no comparison and no competition to that element. So pills, injections, vacuum device, intraurethral gels, they are distant compared to your natural. But a penile implant, that'll get you a decent honorable mention, second place. Because now I can walk around and perform anywhere I want. So now you see what the allure is on patients seeking it. So let's say I already told you about the psychogenic. What about the guy that's very, very ill, right? I'm a transplant patient. I've had 4 surgeries in my belly. I have uncontrolled diabetes. I mean, there are some organic deck of cards, I tell my patients, that, sir, your deck of cards that you're giving me, it's not me not wanting to help you, but the deck of cards that you're giving me, and part of it might not be your fault, right? It's just the nature of the game. But it is impossible to ethically offer you a penile implant because you're too sick. It's too risky. This is elective surgery. This isn't cancer life-saving surgery. This is elective surgery. Dr. Fernandez and I are passionate about it, and we want to help you, but we cannot. We will not put you in danger for this elective surgery. So I'll pause there.
And so that's good, right? That's a good thing. You almost sound like somebody out there would take that risk because there's another procedure Like I remember the HIFU days for prostate cancer, where some of these guys were taking people even without a biopsy to like Mexico to do HIFU, right? They were like
Absolutely.
unscrupulous.
Absolutely.
It almost you almost sound like somebody, buyer beware a little bit. Is that what I'm guessing here?
Dr. Fernandez, myself, and Dr. Parker, we've had patients that are willing to sign whatever form to sort of get us free from any liability and said, Carrion, please take my case. I don't care if I die on the table. I want to know that we at least gave it one last shot. So you could see the drive on some of these individuals.
Yeah. Guys, I have these discussions often with, men typically define their manhood based on their last sexual ability to perform, right? Whether you agree or not, many men do, right? Men, and some people are like, well, that's silly. Well, this is the way it is, right? That we, testosterone is, we're silly with that powerful chemical. Hey, so we spoke about Andres Garcia, who had 3 implants. The wear and tear was significant. What's to say? Or is there a better quality now, so that the revisits of these implants are less so than they used to be? What's happening now?
So, I mean, definitely, if we were to compare the implant, the quality of the implant now, even versus the one 10 years ago, definitely we've come a long way since they first were developed in 1974. So, definitely we have seen much, much improvement. But also at the end of the day, I mean, just like with any mechanical thing, things can go wrong. And they may not necessarily be related to patients, but also, I mean, sometimes just its use and how much you're using it, the maintenance that you give it. Are you cycling it on a regular basis? Are you not cycling or pumping, inflating and deflating the device, even if you're not using it? Like all that stuff, we try and teach the patient that, but definitely the quality and the life of the implant now versus 10 years ago is a lot better. I mean, nowadays, typically at 10 years, between 85 and 90% of the implants are going to be working. So I mean, definitely the half-life, the half-life of the implant is actually really, really great compared to what it was 10, 15 years ago. But the patients also, and I emphasize this a lot to the patients. At the end of the day, even though there has been like a lot of moving forward with it, it's still a mechanical device. So mechanically, it can still go wrong. There's nothing perfect, but compared to how it was, they're almost indestructible. Almost. I mean, there are
how many revisits do you guys see? Revisit penile implants do you guys see on let's say a year? How many do you have?
Oh my goodness.
Roughly. You don't have to be exact. I wonder.
You mean those that received an implant and come back?
For where it's worn out and you have to do another implant.
I mean, we see a lot of referrals also. So I think at least, and I don't know, Dr. Carrion, you can correct me if it is different as to when I was more with you in clinics 5 years ago, but I think almost half of the patients that we're seeing are patients that are what we call virgin patients, in terms of that they have never had an implant, and almost the other half is patients that they've had an implant that has failed, or they had an implant and for some reason it was removed. And granted, being a tertiary center, we like a lot of people or other urologists send those patients over, but I think I would probably say it would be like half and half.
Yeah, which is crazy, Gio, because the common implant candidate around the country is a guy who's getting it the first time. But us in Tampa, and we're a multi-hundred-a-year implant account, 50% is some sort of revision or tweak because something has gone wrong. And that's what we're known for. And that we actually enjoy that, even though it's a little bit challenging.
Right. Those revisits you have to fix. So does it mean remove that implant and place it with another one, or you can fix the one that's already in there?
100 combinations, but that is one master template.
Yeah. Wow.
Yeah, I mean, for the most part, some of the patients that we're seeing, their implants may still be working, but their pump is kind of like now moving a little bit higher than, or they're sitting on it. I mean, it's not necessarily that their implant is not necessarily working, but they're not entirely happy with the end result with it. And that's when we have half of our patients that come in and see us, is so that we can make some tweaks on those previous surgeries so that we can help them out.
I've seen when I worked with Dr. Valenzuela, I saw men kind of after their surgery, press the pump and get an erection and so forth. At that time, and I haven't been in a room with a guy with a penile implant in a while, but at that time, I remember that they needed some good manual dexterity in order to even, press that pump. What does that feel? How strong do their hands, as men get older, if they're frail and they can't squeeze the pump, then that's it. Maybe that's one of the times that they can't get an implant. Is it easier now? I don't know what's even the right term. Is it softer, easier now than it used to be, where you don't have to have, your hands don't need to be as strong?
That's a great comment. Not just strength, but dexterity. Keep in mind that
Yeah.
we also have paralyzed people
Yeah.
that get implants.
Yeah.
Here's my 2 cents without getting politically incorrect with vendors, right? There is a difference on which one is a little easier to inflate than the other. And there is a little difference on which one's a little easier to deflate. But here is the take home that's dear to me that you just set me up for.
I know.
The malleable implant. The malleable implant. It's the forgotten implant. We have a national article last year about the forgotten implant. And guess what? We forgot about it during this podcast. It's not La Bombita, but it's the two rods that are bendable. Now I have a guy that's 77, diagnosed with Parkinson's 5 years ago, right now currently okay, but guess what his next 10 years are going to be? Rocky. And he's not going to be able to inflate it. Even if he tells me, but right now, Carrion, it'll work. My hands are okay. They're good enough. But sir, let's look at the crystal ball and see how you're going to do the next 10 years. It's going to be too risky and you're not going to be able to use it. But if I give you a malleable, not only will it never fail because it's not an inflatable, you're never going to be out of the game. Bingo. Now you're really catering to your patient's needs. So on those patients that you accurately assessed, people get older, they get blind, their coordination is bad, their strength is bad, they can be paralyzed. So many things happen as we age. Malleable implant is outstanding option.
Well, now you opened up just when I thought I was like, okay, this is the final comment, you opened up another set of things because as a non-practitioner in penile implants, I'm thinking of implant into the implant. So break this down for us a little bit, one of you guys. When the patient, because look, there's a lot of conversation on shared decision making, right? Shared decision making. That's the term. But the patient doesn't know what they don't know. So shared decision making? They're going to say something they read on the internet. And one of the things that at least makes this podcast different is that I bring the top people in any of these subjects to come on to really empower the patient to have better conversations and know more, right? So what are the different types of implants? Somebody goes and in order for them to have, because if it's not offered somewhere in the Midwest or something, it's not offered. So what is it that they're looking for? What are the questions they need to ask? And what are the different types of implants?
Raul?
So I mean, like you were saying, shared decision making. When the patient comes in and they're planning on moving forward with an implant, or they come in asking for an implant, for the most part, almost all patients or most patients, what they know is either the inflatable or, like you correctly said, it, la bombita. So that's what most popular. But even if they tell me, oh, I want the inflatable or la bombita, that's the one I want, I'm like, perfect. But nah, it's my responsibility as a provider and as the expert on this to tell him, hey, there are two types of implants. There's the inflatable and then there's the malleable. And I show them both models, even if they have made their mind that this is that the inflatable is the one they want. I give them both options because I want to make sure that when they're making that decision, because it's like Dr. Carrion was mentioning, this is elective surgery, life-changing elective surgery. So when they make that decision, I want to make sure that they have all the information to their grasp to say like, hey, yeah, they offered me both, but this is the one I want. Because I'd rather have that than be the person that, oh, no one told me about this malleable implant, and that would have been a lot better because now I can't pump my device and now I haven't been able to use it for the past year. So definitely when that patient comes in, regardless of what type of implant, even if they ask for one, it's my responsibility as a provider, as the urologist, to tell him, hey, these are the two options. Is this the one that you want, that you told me that you wanted? I just want to lay it out here that there's also these other options, just so you know that there's other options, not only what you know. And for the most part, if they've made their mind, hey, they've made their mind. But at least I know that we're offering them both options. And actually, even today, I had two patients that they came in saying, "This is what I want," and one of them we booked to get.
How do
the
they know what they
inflatable.
want?
Oh,
Like, how do they know what? I mean, I know there's stuff on the internet,
thanks.
but you know,
Probably thanks to podcasts like this and just being like talking more about this and definitely more and more like information, not with with like online internet or like social media, like things, the information is more out there. And the other guy that he came in thinking he wanted an inflatable, he was like, him and his wife were like, yeah, at the end of the day, they were like, yeah, we don't, this looks way too complicated. I would rather just have this. And if it's the same, I would rather just have this and be over with it. So, I mean, that's the importance of being or of showing and being able to provide the patients both options so that they know what's out there. So when they're making that decision, they know that they're making the right decision, and we're here to support them. It's our role as the urologist to give them all the information and help them make the decision, but within what they want.
so we have two options: inflatable, and the other one is malleable. The malleable, you actually have to pump. How does the inflatable one work?
So it would be the other way around.
Opposite.
Oh, sorry.
The inflatable one would be the one that you'd be pumping from with the pump that's placed on the scrotum and the fluid that's on the reservoir goes into the cylinders, and then the malleable one where it's malleable, so you just bend it. Just because it's malleable doesn't. Some patients may think that the rigidity is less or that it's not enough for penetration, when the reality is that both implants provide adequate rigidity both for vaginal and anal penetration. So regardless of what type of implant they want, the rigidity that they're going to be getting with both type of implants is enough for sexual activity. So it's a matter of what they prefer.
And Gio, there's an odd concept with the malleable. You're always erect, right? We get that response all the time. And in fact, other providers are like, well, I'm not going to give that. My client's not going to want that because you're erect all the time. It is so concealable and user-friendly,
Right.
not an obstacle. And you said, do providers, Raul gave an awesome description on what a provider should be doing. When it comes to the malleable, there's a reason why I use that little cute forgotten implant. I would venture, I have no data, but I would have to venture 75% of urology offices around the country don't even mention that as an option.
I don't think I've never heard of it.
Yeah, it's crazy.
I've never heard of it. And so malleable, I just want to kind of, I was going to say have a picture in my head, but maybe not too strong of a picture. So malleable is no pumping.
No.
And so, yeah, I would think that you walk around with an erection. So is it flaccid? When they're walking around, can they walk around with their swim shorts on the beach and not look, different?
So here's the you don't offer a malleable. If you're a nudist, you don't offer.
Yeah.
Okay.
If you're Gio, that Speedo guy on the beach, you don't do a malleable.
Okay.
If you're a sports or semi-professional sports athlete in a public locker room with 50, 60 other teammates, you probably don't want a malleable because you're always erect. Just picture here's the easiest way I give layman wise. 2 sticks, and it's always hard, but it's bendable sticks like clay or aluminum. Those are kind of the best describers I say, but you're always erect and it's always hard.
I'm super excited about today's sponsor, which is Mr. Happy XY Vigor, a formulation to enhance testosterone levels and promote sexual function. Mr. Happy XY Vigor, or XYVGGR, was formulated by yours truly to optimize male hormones and free up testosterone and improve sexual health. It has an abundance of L-citrulline, which helps dilate and open up blood vessels so there's more circulation going into the pelvic area for better erections. Try Mr. Happy XY Vigor today. All right. Wow. This is, I tell you, this is a masterclass on penile implants. This is a masterclass. Guys, I want to thank you so much for your time and knowledge and expertise in this area. It's always good to know that there's a place of excellence in one particular area. And it's good to know that, University of South Florida, led by you, Raphael, are, one of the preeminent, it sounds like, male reproductive centers in the country. And I love that kind of stuff. So thank you so much for coming on. It's been a true pleasure. And again, I've learned so much. Final words, and how can people find you, Raphael?
Well, we have a good online print. We have various 2 websites, right? Florida Sex Health, and as well as our University of South Florida website. Those are probably the easiest ways to navigate, especially for those that don't live close to us. We do have an automated service in terms of trying to make appointments. Like all large institutions, Gio's school is much bigger than ours at NYU. And yeah, that's a big hassle for the call center to try to get people fitted in efficiently. I think our school tries to do a good job. But again, it is a tough task. But absolutely, we're always accessible and available. And we look forward to serving any of our patients.
Thank you very much. Raul, final words or?
Yeah, no, so just echoing what Dr. Carrion said, I mean, they can find us on FloridaSexHealth.com. They can also go through the USF website, through the urology department. And I mean, at the end of the day, what we're here for is to make sure that patients are able to get all the options and being, at the end of the day, what we wanted to bring the patients back into the game. And either with oral medications, injections, penile implants, whatever we need to do in order to make them back into the game and give them that confidence and being able to make them lead and continue leading a healthy sexual lifestyle. That's what we want here. So we're here for them. So, and it was a pleasure for you having us. And I really look forward for us working more and more in the future for sure.
Well, send me all the natural guys, and I'll send you all the malleable implant guys. Wow, that was good. That's my favorite of this. That was my favorite. Guys, thank you so much. I appreciate your time and your expertise here. Thank you.
Thank you again, Gio.
Everyone, thank you so much for listening. Look, this was a masterclass. It really was. Penile implants. It's a thing, and it's a good option for many people who wants to stay in the game. So thank you for listening. Thank you for supporting this show. And always remember to like and comment on YouTube or any platform you listen to your podcast. Thank you very much. This is Dr. Gio signing off. Much love. Talk to you next time. Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Gio Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.